Dr. Harris is managing a trauma patient who was involved in a high-speed motor vehicle collision. The patient has a Glasgow Coma Scale (GCS) score of 7, is unconscious, and has a suspected cervical spine injury. What is the most appropriate initial airway management strategy for this patient, and how would you proceed with cervical spine immobilization? Answer: given the patient's GCS score of 7, the patient is at high risk for airway compromise, and securing the airway is the first priority. In this scenario, intubation is often required due to the low GCS score and loss of protective airway reflexes. However, since the patient has a suspected cervical spine injury, cervical spine immobilization is critical to prevent any further neurological damage. Initial steps: perform manual and line stabilization of the cervical spine before any airway intervention. Use a supraglottic airway device or an endotracheal intubation if needed, being mindful to limit head and neck movement during the procedure. If the patient is not easily intubated, consider using a video laryngoscope or awake intubation if the patient is still responsive. After securing the airway, proceed with further trauma management, including advanced trauma life support, ATLS protocols, and obtain imaging ET or MRI for cervical spine evaluation. The key guidelines for airway management in trauma are outlined by ATLS, Advanced Trauma Life Support, which emphasizes the protection of the cervical spine and securing the airway as early as possible to avoid secondary injury. 56-year-old male presents to the emergency department with severe shortness of breath, hypotension, and diaphoresis. His CG shows evidence of an acute myocardial infarction (STEMI), and he is in cardiogenic shock. What are the key management principles for cardiogenic shock in the setting of STE, MI, and what are the indications for mechanical circulatory support? Answer: cardiogenic shock is a state of inadequate tissue perfusion caused by the heart's inability to pump effectively, often due to acute myocardial infarction (MI). The first step in managing cardiogenic shock is to optimize coronary perfusion and stabilize the hemodynamics. Key management steps: revascularization should be performed as soon as possible. This can include percutaneous coronary intervention (ECI) or thrombolysis if PCI is not available. Inotropic support: medications such as dobutamine or dopamine may be required to improve myocardial contractility. Vasopressors: medications like norepinephrine may be needed to support blood pressure. Mechanical circulatory support e.g. intra-aortic balloon pump left ventricular assist device (LVAD) may be necessary if the patient remains hemodynamically unstable despite pharmacological therapy. Indications for mechanical circulatory support: persistent hypotension despite adequate fluid resuscitation and inotropic support, severe left ventricular dysfunction with inadequate perfusion. A 62-year-old woman presents to the emergency department with chest pain, nausea, and diaphoresis. Her CG shows sense segment depression in leads II and F. Cardiac biomarkers, troponin, are elevated. What is the most likely diagnosis, and how should you manage her treatment initially? Answer: the patient's symptoms and diagnostic findings suggest acute coronary syndrome AX, specifically unstable angina or a non-stelvation myocardial infarction, and STEMI. Given the sense segment depression and elevated cardiac biomarkers, troponin, the presence of elevated troponin is indicative of myocardial injury, although the absence of significant sense segment elevation on CG differentiates NSTE, MI from STE. MI initial management includes antiplatelet therapy, administer aspirin unless contraindicated, and consider PI inhibitor e.g. clopidogrel, ticagrelor to reduce platelet aggregation. Anticoagulation: initiate heparin or low molecular weight heparin LAUH to prevent further thrombus formation. Nitrates: administer nitroglycerin to relieve chest pain and reduce myocardial oxygen demand. Analgesia: provide adequate pain control, typically with morphine if needed for pain relief. Early risk stratification: based on clinical features, CG and biomarkers, consider early cardiology consultation for possible PCI or coronary angiography. Mr. Nguyen is a 29-year-old male who sustained multiple injuries in a fall from a height, including suspected pelvic fractures, open femur fractures, and abdominal pain. He is hypotensive and tachycardic upon arrival at the emergency department. What is the initial management protocol for this patient based on the ATLS, Advanced Trauma Life Support, guidelines? Answer: Mr. Nguyen presents with multiple life-threatening injuries, and immediate application of ATLS protocols is essential. The goal is to stabilize the patient and prevent further deterioration while identifying and addressing life-threatening injuries. Stepwise approach: primary survey airway. Ensure the airway is patterned. If necessary, secure the airway using appropriate methods, intubation or supraglottic devices, while maintaining cervical spine protection. Breathing, assess for any signs of respiratory compromise, such as tension pneumothorax or hemothorax. Administer oxygen if needed and consider chest tube placement for pneumothorax or hemothorax. Circulation. Establish 2 large bore IV lines and begin fluid resuscitation with crystalloids, e.g. normal saline or Ringer's lactate, to counteract hypotension. Consider blood transfusion if hemorrhagic shock is suspected. Disability. Assess neurological status using the Glasgow Coma Scale (GCS) and check for signs of head injury or spinal cord injury. Exposure. Fully undress the patient to assess for hidden injuries but maintain warmth to prevent hypothermia. Secondary survey. After the primary survey, conduct a more thorough physical examination and obtain imaging studies, e.g. CT scan of the abdomen and pelvis to assess for internal bleeding, X-rays to evaluate bone fractures. A 65-year-old male presents in cardiac arrest with no pulse or respirations. His rhythm is ventricular fibrillation, BF. What are the critical steps in managing this patient according to the Advanced Cardiovascular Life Support (ACLS) guidelines, and how does the use of defibrillation impact outcomes? Answer. In this scenario, the patient is in ventricular fibrillation, VF, which is a life-threatening arrhythmia requiring immediate defibrillation. The ACLS guidelines outline the following critical steps in managing VF cardiac arrest. Immediate high-quality chest compressions. Begin CPR with high-quality chest compressions at a rate of 100-120 min and depth of at least 2 inches, allowing full chest recoil between compressions. Defibrillation. Deliver a shock using an automated external defibrillator, or manual defibrillator at 200 joules for biphasic waveform or 360 joules for monophasic waveform. Defibrillation is essential to restore a perfusing rhythm. Post-shock CPR. Continue CPR immediately after defibrillation for 2 minutes, then reassess the rhythm. Drug administration. Administer epinephrine 1 mg every 3-5 minutes during the resuscitation attempt. If VF persists, administer amiodarone 300 mg IV push followed by a second dose of 150 mg if needed. 40-year-old female presents with second-degree burns covering 30% of her total body surface area TBSA after a house fire. What is the initial management, including fluid resuscitation, for this patient, and what formula should be used for calculating the volume of fluid required? Answer. For this patient with second-degree burns covering 30% of her total body surface area TBSA, the primary goal is fluid resuscitation to restore intravascular volume and prevent shock. The most widely used formula for burn fluid resuscitation is the Parkland formula. The Parkland formula is 4 ml weight kg x TBSA percent for the first 24 hours. For this patient, the calculation would be 4 ml 70 kilograms assumed weight, EC 30 P was 8400 ml fluid required over 24 hours. Half of the volume, 4,200 ml, should be administered within the first 8 hours post-burn, and the remaining half, 4,200 ml, should be given over the next 16 hours. This fluid should be given with lactated Ringer's solution as the preferred crystalloid. Additional care includes pain management, wound care, and infection prevention. A 75-year-old man presents with fever, confusion, and hypotension. His heart rate is 120 bpm, and his blood pressure is 85/60 mmHg. Lab results show elevated lactate levels, and he is a positive urine culture. What is the initial management strategy for this patient, and what are the key components of the sepsis bundle? Answer. This patient is presenting with signs of sepsis likely from a urinary tract infection, UT, as suggested by the positive urine culture. The initial management involves fluid resuscitation. Begin with IV fluids, e.g. normal saline or Ringer's lactate, to restore intravascular volume. The goal is to achieve adequate perfusion with improvement in blood pressure and lactate levels. Antibiotics. Administer broad-spectrum antibiotics promptly after blood cultures and urine cultures are obtained. Once sensitivities are known, antibiotics can be narrowed. Vasopressors. If hypotension persists despite adequate fluid resuscitation, initiate norepinephrine to maintain mean arterial pressure, MAP 65 mmHg. Key components of the sepsis bundle. Measure lactate levels. Obtain blood cultures before antibiotics. Administer broad-spectrum antibiotics within the first hour. Provide fluid resuscitation and monitor response. A 58-year-old male presents to the emergency department with sudden onset right-sided weakness, difficulty speaking, and facial droop. His last known well was 2 hours ago. What are the next steps in the diagnostic workup and treatment, including thrombolysis eligibility? Answer: this patient's presentation is suggestive of an acute ischemic stroke. The initial steps in management are rapid neurological assessment, perform a neurological exam and assess using the NIH stroke scale. NIST to quantify the severity of the stroke, non-contrast CT scan, perform a CT scan of the brain to rule out hemorrhagic stroke as thrombolysis is contraindicated in hemorrhagic stroke. Eligibility for thrombolysis. If the CT scan rules out hemorrhage and the patient is within 4.5 hours of symptom onset, consider IV tissue plasminogen activator (EPA) to dissolve the clot and restore blood flow. Thrombolysis should be administered in a certified stroke center under close monitoring. Endovascular thrombectomy. For patients with proximal arterial occlusion and symptom onset within 6 to 4 hours, consider mechanical thrombectomy. The goal is to restore perfusion as quickly as possible to minimize neurological damage. A 5-year-old boy presents with wheezing, difficulty breathing, and a history of recurrent respiratory infections. His vital signs are HR 150 BPM, RR Fortamin, and SPO 88% on room air. What is the initial management of this patient suspected of having an asthma exacerbation? Answer: this patient's presentation is consistent with an acute asthma exacerbation. The initial management includes oxygen therapy, administer oxygen to maintain SPO 92%, BACE agonists, administer nebulized albuterol short-acting BACE agonist to relieve bronchospasm, systemic corticosteroids, administer oral or IV steroids, e.g. prednisone, methylprednisolone, to reduce inflammation, continuous monitoring. Assess respiratory status frequently, including using a peak flow meter to gauge the severity of the exacerbation. Ipratropium bromide may also be used in combination with albuterol for more severe cases. A 45-year-old woman presents with acute upper abdominal pain radiating to the back, nausea, and vomiting. Her serum amylase and lipase levels are significantly elevated. What is the initial management of acute pancreatitis and what are the indications for further intervention? Answer: the patient's presentation is consistent with acute pancreatitis. Initial management includes supportive care, IV fluids to maintain hydration, pain management with analgesics, e.g. acetaminophen, or opioids for severe pain, NPO, nothing by mouth. The patient should not eat or drink until the acute symptoms resolve. Electrolyte management. Correct any electrolyte imbalances, e.g. hypokalemia, hypocalcemia. Antibiotics are not routinely indicated unless there is evidence of infection such as pancreatic abscess or pseudocyst. Indications for further intervention. Necrotizing pancreatitis or complications like infection require more intensive management, possibly including antibiotics or drainage procedures. Guidelines emphasize early fluid resuscitation and supportive care to avoid complications and reduce mortality. In modern healthcare systems, the emergency department (ED) plays a crucial role in providing timely care to patients. What are the core responsibilities of the ED in terms of healthcare delivery, and how does it interact with other parts of the healthcare system to ensure continuity of care? Answer: the ED serves as the primary point of access for patients requiring urgent medical attention, especially for life-threatening conditions. Core responsibilities of the ED include triage and initial assessment. The ED must quickly assess the severity of conditions to prioritize care based on the principle of triage. Emergency stabilization and treatment. Immediate medical intervention is provided to stabilize critically ill or injured patients. Referral and coordination. The ED facilitates referrals to specialists or inpatient care when necessary, ensuring continuity of care after discharge. The ED functions within a systems-based approach to care, which involves effective communication and coordination with primary care providers, specialists, and other departments such as radiology or laboratory services. The goal is to ensure that the patient receives comprehensive care after their initial emergency treatment, addressing both immediate and long-term health needs. In emergency situations, informed consent is often complicated by the need for immediate intervention. What ethical challenges arise when a patient is unconscious or unable to provide consent, and how do medical professionals balance autonomy with beneficence in such cases? Answer: the ethical principle of autonomy allows individuals to make decisions regarding their own healthcare. However, in emergency settings where a patient is unconscious or unable to provide consent, healthcare providers must rely on the principle of beneficence, which emphasizes acting in the best interest of the patient. In cases where a patient cannot provide consent, emergency physicians may assume implied consent in life-threatening situations. This means that medical professionals are authorized to perform necessary procedures under the assumption that the patient would consent if they were capable. Legal framework. The Emergency Medical Treatment and Labor Act (EMTALA) requires that all patients receive a medical screening examination and stabilizing treatment, regardless of their ability to pay or provide consent. When the patient cannot provide consent, treatment is justified based on medical necessity and the principle of saving life or preventing harm. Mr. Johnson, the 60-year-old male, arrives at the emergency department in severe respiratory distress. He is unable to communicate effectively due to the severity of his condition. After initial assessment, the physician suspects acute respiratory failure. What should the physician consider in terms of ethical and legal requirements before initiating treatment, and what actions should they take? Answer. In this case, the physician must balance the ethical principles of autonomy and beneficence. Since Mr. Johnson is unable to communicate or provide consent, the physician is justified in applying implied consent, a concept rooted in beneficence, to provide life-saving treatment. Ethical considerations. Autonomy. Mr. Johnson's autonomy is respected by assuming that he would consent to life-saving treatment if he were able to do so. Beneficence. The physician must act in the patient's best interest by administering the necessary treatment to stabilize his condition. Legal considerations. Under EMTALA, the physician is obligated to stabilize the patient regardless of consent, as long as it is a medical emergency. If a family member or legal surrogate is available, the physician should attempt to obtain consent from them, but immediate life-saving measures can be initiated without it. In an emergency situation where a patient is unable to speak and no family members are present, how should healthcare providers handle the confidentiality of the patient's medical information, particularly when a third party requests access to it? Answer. In emergency situations, patient confidentiality remains a fundamental principle. However, healthcare providers must also navigate situations where third parties, such as law enforcement or family members, request access to the patient's information. Legal framework. According to the Health Insurance Portability and Accountability Act, HIPAA, patient information should only be shared with individuals or entities authorized to receive it. In the absence of consent, providers must assess whether the third party's request is legally valid. In cases where the patient is incapacitated, confidentiality is still upheld and medical records can only be disclosed to those with legal authority, such as a legal guardian or authorized representative. The healthcare provider must ensure that any release of information complies with HIPAA rules and protects the patient's privacy while also addressing the medical needs of the situation. Active handoff communication between healthcare teams in the emergency setting is crucial for ensuring continuity of care. What are the key elements that should be included in a structured handoff communication process, and how do they impact patient safety? Answer. A structured handoff process is vital to ensure that critical patient information is transferred clearly and accurately between healthcare teams. The key elements of effective handoff communication are patient information. This includes the patient's identification, medical history, current condition, and any immediate concerns. Clinical status. A clear summary of the patient's vital signs, laboratory results, and ongoing treatment or interventions. Plan of care. Detailed information about the next steps in the patient's care, including any procedures, medications, or follow-up actions required. Concerns and risk factors. A summary of potential complications or red flags that the next team needs to be aware of. Impact on patient safety. Effective handoff communication reduces the risk of medical errors and ensures that all providers are aware of the patient's condition and treatment plan, preventing lapses in care and promoting safety. What does the principle of justice mean in the context of emergency care, and how does it apply to the distribution of limited healthcare resources in an emergency setting? Answer. The principle of justice refers to the fair and equitable distribution of healthcare resources, ensuring that all patients are treated with fairness and impartiality. In an emergency setting, this becomes critical when resources are limited, such as in mass casualty events or during times of high patient volume. Application of justice. The healthcare team must prioritize care based on medical need, giving the most critical patients the immediate attention they require while ensuring that less urgent cases do not receive preferential treatment. Triage systems such as the START, simple triage and rapid treatment. system help in determining the urgency of care based on the severity of the patient's condition, thereby ensuring that resources are allocated efficiently and fairly. The goal is to achieve the best possible outcomes for the greatest number of people, ensuring that no one is unjustly disadvantaged due to socioeconomic factors or other biases. What are some of the key milestones in the development of emergency medicine as a specialty, and how have these milestones shaped modern emergency care practices? Answer: emergency medicine evolved as a distinct medical specialty in the mid-20th century, with several key milestones. The emergence of trauma centers. In the 1960s and 1970s, trauma care was formalized through the creation of dedicated trauma centers, leading to improved patient outcomes in cases of severe injury. The formation of professional organizations. The American College of Emergency Physicians (ACEP) was established in 1968, advocating for standardized education, training, and credentialing for emergency medicine professionals. Advances in triage and pre-hospital care. The development of pre-hospital care, including paramedics and emergency medical services (EMS), revolutionized patient transport and triage, allowing for quicker and more efficient emergency care delivery. These milestones have shaped modern emergency medicine by enhancing the standardization of care, improving outcomes for trauma patients, and creating systems to ensure timely, efficient, and effective emergency care. How does cultural competency play a role in emergency care, and what are the potential challenges healthcare providers might face when treating patients from diverse cultural backgrounds? Answer: cultural competency is the ability of healthcare providers to understand, respect, and effectively interact with patients from diverse cultural backgrounds. It involves recognizing cultural differences in values, beliefs, and behaviors, and adapting care to meet the unique needs of each patient. Challenges in emergency care. Language barriers. Miscommunication due to language differences can delay treatment or lead to misunderstandings about the patient's condition or history. Cultural beliefs. Some patients may have cultural or religious beliefs that impact their acceptance of certain medical treatments or interventions. Bias and stereotyping. Unconscious biases may influence how healthcare providers interact with patients, affecting the quality of care. Addressing these challenges requires a commitment to providing culturally sensitive care, using interpreters when necessary, and being mindful of patients' cultural preferences in treatment decisions. What are the common legal issues related to medical malpractice in emergency medicine, and how can emergency healthcare providers mitigate the risk of malpractice claims? Answer: medical malpractice in emergency medicine can arise from various issues, including failure to diagnose, delayed treatment, and inadequate documentation. Common malpractice cases include failure to provide a timely diagnosis, especially in life-threatening conditions like myocardial infarction or stroke, negligent discharge of a patient without appropriate follow-up care or instructions, errors in administering medication or performing procedures. To mitigate the risk of malpractice claims, emergency healthcare providers should ensure thorough documentation of all patient interactions, assessments, and decisions, follow established clinical protocols and guidelines for common emergency conditions, engage in informed consent practices, especially in situations requiring urgent interventions. How has the advancement of technology influenced emergency medicine, and what are some key innovations currently shaping emergency care practices? Answer: technological advancements have profoundly impacted emergency medicine, improving patient outcomes and the efficiency of care delivery. Key innovations include telemedicine. Remote consultations allow emergency physicians to assess and manage patients, particularly in rural or underserved areas. Electronic health records (EHR) systems streamline patient information sharing, improve documentation accuracy, and allow for real-time access to medical histories. Point-of-care testing. Devices like portable ultrasound machines and blood gas analyzers enable rapid diagnostic testing at the patient's bedside, speeding up decision-making in critical situations. These innovations enhance the ability of emergency care providers to deliver timely, accurate, and personalized care, improving patient outcomes in emergencies. 45-year-old male presents to the emergency department with hematemesis. He has a history of chronic alcohol use and was recently diagnosed with cirrhosis. On examination, he is tachycardic and hypotensive. What is the most likely cause of his bleeding, and how should it be managed? Answer: due to portal hypertension. The portal vein is obstructed in cirrhosis, leading to elevated pressure in the veins of the esophagus, which may rupture, causing significant bleeding. The clinical presentation of hematemesis, vomiting blood, is a hallmark of this condition. The patient is also hypotensive and tachycardic, signs of shock due to the blood loss. Management begins with resuscitation to stabilize the patient. Intravenous Romainoids should be given promptly to restore circulating volume, and blood transfusions may be required if significant blood loss is evident. In addition, octreotide vasicin stricta or vasopressin can be used to reduce portal venous pressure and control bleeding. Endoscopic therapy is the next step for definitive management. The procedure involves banding or sclerotherapy of the varices to achieve hemostasis. If bleeding persists despite endoscopic intervention, a transjugular intrahepatic portosystemic shunt TIPS procedure may be necessary to create a shunt and relieve portal pressure. Patients with cirrhosis and varices should be managed with beta blockers to prevent future bleeds. A thorough diagnostic approach includes an upper gastrointestinal endoscopy to directly visualize the varices and assess their severity. A 28-year-old woman presents with severe epigastric pain radiating to her back, nausea, and vomiting. She reports recent heavy alcohol consumption. Her serum lipase level is markedly elevated. What is the diagnosis and what are the next steps in management? Answer: this patient likely has acute pancreatitis, which is commonly caused by alcohol use and presents with severe epigastric pain, often radiating to the back, accompanied by nausea and vomiting. The diagnosis is supported by a markedly elevated serum lipase level, which is a more specific marker for pancreatitis than amylase. The Ranson's criteria can be used to assess the severity of the condition, which helps in determining the need for intensive care. The initial management focuses on fluid resuscitation to counteract dehydration, as pancreatitis can lead to third space fluid loss. The preferred fluid for resuscitation is isotonic saline or lactated Ringer's solution. Pain management is also crucial, often requiring opioids for control of the severe abdominal pain. In more severe cases where complications like pancreatic necrosis or organ failure are suspected, ICU admission for closer monitoring is recommended. Nutritional support is also important. Early enteral feeding is preferred over parenteral nutrition to support gut function and reduce infection risks. Imaging, typically a CT scan, can help assess the extent of the pancreatic injury and identify complications like pseudocysts or fluid collections. If gallstones are suspected as the cause of pancreatitis, an ultrasound of the abdomen should be performed to assess for cholelithiasis. Mr. Thomas, a 62-year-old male with a history of diverticulitis, presents with acute abdominal pain, fever, and nausea. On examination, he has rigidity and rebound tenderness in the lower abdomen. His white blood cell count is elevated. His CT scan reveals free air under the diaphragm. What should be the next steps in his management? Answer: Mr. Thomas' presentation of acute abdominal pain, fever, and rebound tenderness, along with the finding of free air under the diaphragm on CT, strongly suggests perforated diverticulitis, a severe complication of diverticular disease. The free air is indicative of a gastrointestinal perforation, often caused by a ruptured diverticulum. This condition requires urgent surgical intervention to repair the perforation and prevent peritonitis, a life-threatening infection of the peritoneum. The first step in management is resuscitation with IV fluids, antibiotics to cover gram-negative and anaerobic organisms, and pain management. Broad-spectrum antibiotics such as piperacillin, tazobactam, or ceftriaxone with metronidazole should be started immediately. Surgical consultation is critical, and most patients with perforated diverticulitis require a laparotomy to repair the perforation. Depending on the extent of contamination and patient stability, a Hartmann's procedure, colon resection with colostomy, may be performed, especially in cases with widespread infection or peritonitis. If the perforation is small and localized, primary anastomosis, reconnecting the bowel, may be considered. Postoperatively, the patient should be monitored closely for signs of sepsis or organ failure. A 35-year-old female presents with lower abdominal cramping, fever, and bloody diarrhea. She has a history of intermittent abdominal pain and weight loss over the past few months. Colonoscopy reveals patchy inflammation and deep ulcerations. How can you differentiate between diverticulitis and inflammatory bowel disease (IBD) in this patient? Answer: the clinical presentation and colonoscopy findings of patchy inflammation and deep ulceration suggest inflammatory bowel disease (IBD), most likely Crohn's disease as opposed to diverticulitis. Diverticulitis is typically localized to the sigmoid colon and presents with left lower quadrant pain, often accompanied by fever, nausea, and leukocytosis. The diagnosis is confirmed with imaging such as a CT scan, which shows diverticular and pericolonic fat stranding. Treatment typically involves antibiotics and, in severe cases, surgical resection. On the other hand, inflammatory bowel disease (IBD), which includes Crohn's disease and ulcerative colitis, presents with chronic recurrent symptoms like weight loss, abdominal cramping, and diarrhea. Colonoscopy findings in Crohn's disease typically reveal skip lesions, discontinuous areas of inflammation, and transmural involvement of the bowel, while ulcerative colitis typically shows continuous inflammation starting from the rectum and extending proximally. The patchy inflammation seen in this patient is more characteristic of Crohn's disease. Further diagnostic workup, including stool cultures, serologic testing, e.g., anti-Saccharomyces cerevisiae antibodies for Crohn's, and imaging studies like MRI or CT enterography can confirm the diagnosis. A 56-year-old male with a history of peptic ulcer disease presents with sudden onset severe abdominal pain, vomiting, and fever. On physical examination, his abdomen is distended, with absent bowel sounds and rebound tenderness. What diagnostic tests should be performed to confirm the diagnosis of gastrointestinal perforation? Answer: this patient is presenting with signs of gastrointestinal perforation, which is most commonly caused by peptic ulcer disease but can also result from other conditions such as diverticulitis, appendicitis, or trauma. The acute onset of severe abdominal pain, vomiting, and fever, along with abdominal distension and rebound tenderness, strongly suggest a perforated ulcer or another gastrointestinal perforation. The first step in diagnosis is to perform an abdominal X-ray, which may reveal free air under the diaphragm, a classic sign of a perforation. If the X-ray is inconclusive, or if the perforation is suspected to be in the lower gastrointestinal tract, a CT scan with contrast should be performed. A CT scan is more sensitive and can help locate the source of the perforation, such as an ulcer, diverticulum, or appendicitis, and assess the extent of contamination. A contrast-enhanced study is particularly useful in identifying fluid collections or abscesses that may require drainage. Immediate surgical consultation is required for the repair of the perforation, often involving a laparotomy. In some cases, conservative management with percutaneous drainage may be possible, but surgery is generally the treatment of choice for gastrointestinal perforations. A 22-year-old college student presents with sudden onset vomiting, diarrhea, and abdominal cramping. He ate at a campus cafeteria a few hours before his symptoms began. What is the likely etiology of his symptoms, and how should he be managed? Answer: this patient likely has viral gastroenteritis, commonly caused by norovirus or rotavirus, which are known to cause sudden onset of vomiting, diarrhea, and abdominal cramping within hours of exposure. The patient's symptoms occurring shortly after eating at a cafeteria suggest a foodborne viral infection. Viral gastroenteritis is typically self-limiting and resolves within 1-2 days without the need for antibiotics. Management focuses on hydration with oral hydration solutions to prevent dehydration, especially in young or otherwise healthy patients. However, if there are signs of severe dehydration, or if the patient is at risk for complications, e.g. immunocompromised, intravenous fluids may be required. In contrast, if bacterial food poisoning such as Salmonella, Campylobacter, or Staphylococcus aureus is suspected, particularly with the presence of blood in the stool, antibiotics might be necessary. However, most cases of bacterial gastroenteritis are self-limiting and do not require antibiotics unless there is evidence of systemic infection or high-risk factors. Stool cultures or PCR tests can be performed to differentiate viral from bacterial causes, though these are typically reserved for severe cases. A 60-year-old male presents with hemoptysis and a history of long-term non-steroidal anti-inflammatory drug NSAID use. What is the most likely cause of his bleeding, and how should it be managed? Answer: the most likely cause of this patient's hemoptysis, vomiting blood, is a peptic ulcer or gastritis, both of which can be exacerbated by the long-term use of NSAIDs, which impair prostaglandin production and disrupt the gastric mucosal barrier. The bleeding could be from an ulcer, which can erode into blood vessels, leading to significant hemorrhage. The diagnosis is confirmed by upper gastrointestinal endoscopy, also known as esophagogastroduodenoscopy or EGD, which allows direct visualization of the ulcer and identification of the bleeding source. Management involves initial resuscitation with IV fluids and blood transfusions if necessary to stabilize the patient. Proton pump inhibitors, PPIs, such as omeprazole, are administered to decrease gastric acid secretion and promote ulcer healing. Endoscopic treatment may include thermal coagulation, clit placement, or sclerotherapy to control active bleeding. If the patient continues to bleed despite endoscopic therapy, angiographic embolization or surgery may be required. Additionally, the patient should be advised to stop NSAID use and may need to start H. pylori eradication therapy if an infection is suspected as the underlying cause of the ulcer. 50-year-old male with cirrhosis presents with hemoptysis. His platelet count is low and his INR is elevated. What is the most likely cause of the bleeding, and how should it be managed? Answer: this patient with cirrhosis, low platelets, and elevated INR is most likely experiencing esophageal varices due to portal hypertension, a common complication of cirrhosis. The elevated pressure in the portal vein causes blood to be rerouted to collateral veins, including the esophageal veins, which can become engorged and prone to rupture. The clinical presentation of hemetemesis, vomiting blood, is a classic sign of variceal bleeding. Management begins with resuscitation to stabilize the patient. This includes fluid resuscitation, blood transfusions if necessary, and administration of vasoactive drugs like octreotide or vasopressin to reduce portal pressure and control the bleeding. Endoscopic therapy, such as banding or sclerotherapy, is the definitive treatment. If endoscopic therapy fails, TIPS, transjugular intrahepatic portosystemic shunt, or surgical interventions may be necessary. It's important to continue beta blockers like propranolol for long-term prevention of variceal bleeding in patients with cirrhosis. A 50-year-old woman presents with right upper quadrant pain, fever, and nausea. Her laboratory results show an elevated white blood cell count and bilirubin levels. An ultrasound reveals thickened gallbladder walls and the presence of gallstones. What is the diagnosis and what is the management plan? Answer: this patient's symptoms and imaging findings are consistent with acute cholecystitis and inflammation of the gallbladder, often due to obstruction by gallstones. The clinical presentation typically includes right upper quadrant pain, fever, and nausea, while laboratory findings may reveal an elevated white blood cell count, leukocytosis, and liver enzymes, bilirubin, AST, ALT. Ultrasound is the primary imaging modality for diagnosing cholecystitis and can show gallstones, thickened gallbladder walls, and pericholcystic fluid. The management of acute cholecystitis includes supportive care, pain control, IV fluids, and antibiotics, broad-spectrum antibiotics like cephalosporins or piperacillin tazobactam to treat infection. The definitive treatment is cholecystectomy, ideally performed within 72 hours to reduce the risk of complications like perforation, gangrene, or abscess formation. If surgery is not feasible due to comorbidities, percutaneous cholecystostomy may be performed in high-risk patients to relieve symptoms and drain infected bile. A 55-year-old male presents with jaundice, dark urine, and abdominal discomfort. He has been on acetaminophen for chronic pain management. His liver function tests reveal elevated ALT and AST levels. What is the likely cause of his liver injury and what steps should be taken? Answer: this patient's symptoms of jaundice, dark urine, and elevated ALT levels suggest acetaminophen-induced liver injury, a common cause of acute liver failure. The patient's history of chronic use of acetaminophen increases the risk of overdose, especially if doses exceed the recommended daily maximum, leading to the accumulation of the toxic metabolite NAPQI, N-acetyl P-benzoquinonamine. N-acetylcysteine, NAC, should be administered promptly as the antidote, as it replenishes glutathione stores and facilitates the detoxification of NAPQI. If the patient presents late with significant liver injury, options such as liver transplantation may be considered depending on the severity of liver failure and the patient's clinical condition. NAC is most effective when given within 8 hours of ingestion, but it can still be beneficial in later stages. Monitoring the patient's liver function and coagulopathy is essential to assess the need for liver transplant evaluation if there are signs of acute liver failure.